image. And so the period really is just 4 years, and we thought that would be enough to really capture all the blocks that we've done in this period. So the question is then, well, why do we choose to look at serratus anterior plane blocks, or why regional anesthesia in general? So, I mean, trials like the SABRE trial that Chris Harrington and a number of other clinicians in Sydney hospitals have kind of demonstrated that the serratus anterior plane block, or at least regional anesthesia, is superior to opioid analgesia in the management of rib fracture and or thoracic trauma pain, in that it reduces pain or decreases pain scores, it decreases opioid analgesia, and it decreases the complications of impaired ventilation, so particularly like delirium, pneumonia, atelectasis, length of stay, and death. And we also know that because it's a fascial plane block too, the complications of this particular block is actually quite low, with some studies actually reporting no local anesthetic systemic toxicity. But then the question is, well, why this serratus anterior plane block rather than the alternatives that some people may recognise as like the erector spinae block, the PEC blocks, the intercostal nerve blocks, or the paraspinal blocks? And one of the reasons why we chose this one is that the serratus anterior plane block may be pragmatically better, in that you don't need to reposition the patient, and that you can perform this patient supine. And this then brings us to the next point too. So the other thing is, it also anaesthetizes over the anterolateral aspect of the chest wall between T2 and T9, which is a common location where rib fractures and flail occur. So now the next question is, well, why should we do this in the pre-hospital setting? And firstly, there are some advisory groups like this one from Scotland, which just recommends regional anaesthesia as an option for rib fracture related pain. However, there's none that specify that whether regional anaesthesia is superior to parenteral analgesia. The other reasons why we should be doing this is that, well, technically we've got the capability. We have the skill, and we know that these blocks take up to 5.5 minutes, and that there's an 80% success rate when we actually do this. We have the equipment in a bag ready to go with ropivacaine and the spinal needles. And then more controversially, we also have the situational opportunity too, because of the prolonged transport times with getting to a definitive care. And then finally, kind of conceptually too, there's that idea that we want to be delivering the same or better care to the patient when we make first contact. And if this is being identified as a superior option in the hospitals, then we should be considering providing this superior care in the pre-hospital retrieval environment too. So there are some potentially other uses, and this is a bit more controversial, but one of our cases demonstrated that you can use this serratus anterior plane block for essentially penetrating chest injury, which was kind of iatrogenic. So after a intercostal drain was inserted, you can also provide analgesia to that area and make that chest drain more tolerable. And you can either do that before you actually put the chest drain in or after the chest drain, but that's still a bit of a controversial area. But at this point of time, considering penetrating chest injury is a time-critical pathology, we would be advocating not to actually perform it on those kind of patients. But let's get back to the study that we did. So as this consort diagram kind of demonstrates, so we analysed firstly the missions that then had trauma and then that had specifically thoracic trauma. And you can identify that actually over this 4-year period, only 13 patients actually had this particular block, which really represents a really small number, and actually 0.65%. And then based on that, we identified those patients on Air Maestro. We did case reviews, and we were looking at the documentation to look at certain details, such as like the patient demographics, injury patterns, and then particularly the procedural aspects like the dose of ropivacaine, the diluent, and things like that. And then afterwards, we then enlisted the assistance of our Liverpool radiologist to actually interpret the CT chest imaging to identify if there was any fluid in the serratus anterior plane as a measure of to confirm that it's been appropriately performed. So there's one way to kind of conceptualize the results is kind of breaking it down into like that right patient, right time, right care. And the first primary outcome of our study was to work out whether we were identifying patients that would benefit from this serratus anterior plane block. And to be considered appropriate, we had three criteria. That one, it was a patient that was performed on a patient with blunt thoracic trauma, that the patient had at least moderate pain, and that was kind of characterized by more than 4 out of 10 pain based on a verbally reported score, or descriptions of distress or unable to move, for example. And then the third criteria was that they had to have received a minimum analgesic dose beforehand. And so that was any ketamine or at least 0.1 milligrams per kilogram of morphine or 1 microgram per kilogram of fentanyl. And so if they met that criteria, then we thought that, yes, this patient was appropriately selected, and 69.2% met that kind of criteria. And we'll talk about whether that was appropriate criteria a bit later. Now, then we went into the kind of secondary outcomes. We're kind of trying to work out, well, whether we actually were providing the right treatment to this patient using that serratus anterior block and whether it was the right time. So one way to determine whether we actually identified the patient with suspected rib fractures was to actually look at the CT imaging and see if they've got fractures. And 76.9% did have it, and so it is an indication for its use. We thought that time-critical pathology was a contraindication for its use, and therefore those patients were potentially not appropriate for the SABRE, and that was 23.1%. And then we kind of wanted to know whether it was technically successful in that whether there was fluid in the serratus anterior plane as diagnosed or identified by our radiologists, and that was 62.5%, so more than 50%, I guess. And then we were looking to see if there was any complications from the use of this block. And one way to identify that was using identifying if the patient required any intubation within 6 hours or had any local anesthetic systemic toxicity, both of which were 0. And so just in case you were kind of wondering what fluid in the serratus anterior plane looks like, this is what our radiologist was interpreting, and you can kind of see this too hypodense fluid adjacent to in the serratus anterior plane. But as with any research, sometimes it raises more questions than it really answers. And so the first one really was the suitability criteria. So I said that 69.2% was deemed suitable, but that was based on criteria of pain and then adequate analgesia. And of the 3 patients that didn't meet that criteria, both had significant improvement in their pain after they actually received the block. And so therefore, maybe a pain threshold of 4 out of 10 or more, or description of distress is maybe not sensitive enough, and that maybe we should be offering this to a wider population of our patients. Then the next one really was about rib fractures. So there were 3 patients who didn't have rib fractures. One patient who was pregnant who didn't have any chest imaging at all, which raises the possibility that maybe she did have injuries, but we just didn't identify it. And the other 2 had underlying pneumothorax, hemothorax, or pulmonary contusion, which one would assume, considering that CT imaging doesn't really report soft tissue injury unless it's significant, would potentially have benefited from the actual SABRE anyway. And we know that because perioperatively for cardiothoracic surgery, they're not going through ribs or anything, and they do still provide the same regional anesthesia to provide pain relief for soft tissue injury, essentially. And so it does raise the question, well, does it matter whether the patient's got rib fractures or not? And as you'll know from hospital practice, we don't determine whether the patient should start on a rib fracture or a chest injury pathway. If we don't discriminate if they do or don't have rib fractures, it's more about the pain in itself, because the pain is what causes them to hypoventilate and then develop complications. The other kind of question was, well, we said time-critical pathology was an absolute contraindication, and there were 3 patients who had those time-critical pathology. However, only one of them required operative management. And in that one, it was actually a really quick scene time of 28 minutes. The other two were managed conservatively. And so the question of what kind of consequence doing a SABRE on scene time on these patients who are going to be managed conservatively is a little uncertain. And so the question is, well, is time critical pathology that's identified, is it an absolute, or maybe it's just a relative contraindication that we have to think about before we consider actually performing this? Then we just talk about briefly the scene time. So there were prolonged scene times with an average about 40 minutes, but we don't really know, based on the research, about what period of that time was spent actually performing this block, knowing that generally it takes 5.5 minutes to perform it. But importantly, there was a transport time of between 13 to 108 minutes. And knowing that the ropivacaine takes effect within 30 minutes, then that, again, any time spent on scene performing this block may be an investment in time, considering also there's often delays once arriving at the definitive care or the hospital to then get blocks or get any further definitive analgesia. We then talked about CT fluid. And so the question is, well, the CT, does it really provide all the evidence that the block has been performed successfully? And there was 62.5% of patients who had CT chests who had fluid in the appropriate area. But of those 3 remaining patients who didn't, there could be a number of reasons why fluid wasn't identified. And for example, like the fluid could be admixed with blood, and we can't distinguish between injury-related kind of fascial plane blood, or whether it's the local anaesthetic has been placed in the wrong area, for example. And then finally, we talked about whether intubation and intercostal drains were present after 6 hours, or for intercostal drains 24 hours. And the question is really, well, does the SABRE prevent or having to intubate this patient by eliminating the respiratory distress, or are we just delaying it? Based on this limited window of 6 hours, we would say, well, it actually doesn't. So it effectively prevents the need for intubation and ventilation, but that is only 6 hours, and we don't know particularly what happens over the next 24, 48 hours when these patients, that's generally when these patients start to deteriorate and actually require intubation. What we did know, though, is that there was no last or local anaesthetic systemic toxicity, but is that really the only proof of safety? And unfortunately, our research didn't really capture anything else, but it would be really difficult to try and distinguish between procedural hematoma, for example, or pneumothorax or hemothorax with an injury associated, like the initial mechanism of injury related kind of complications. And that would require further research too. And then finally, the other thing is that we really had small numbers, where it was only 13 out of 2,004 patients with thoracic trauma, which raises a question. Firstly, were there other patients that people considered doing this block but didn't actually do? And they would be particularly informative. And the small numbers just expose this whole research to lots of bias and error, and kind of, to really quote an ex-president, we don't really know whether what we saw is like true fact or fake news, really. But the conclusions from our study was such that the SABRE is a feasible option for pain related to rib fractures or blunt chest injury. Based on the little parameters or few parameters that we looked at, it does appear to be safe, and that we can perform it successfully when we do decide to do it. But further research is really required, particularly to identify whether it's superior to parenteral analgesia, and whether it particularly helps to avoid any further kind of ventilatory support like intubation, ventilation. But hopefully we can kind of make a young woman look as happy as she does. But really, let's talk about how this applies to you. So firstly, considering there was such few numbers over the last 4 years, it's really a block that we should be considering as an option for patients with isolated rib fracture or chest injuries for the reasons I kind of mentioned. The other point is really that this type of block is increasing in popularity in hospital, and I think you can anticipate that this will also overflow into the pre-hospital environment too, and such that we will see more of them being performed on our patients. We can anticipate further training and much very soon in this afternoon. And finally, there was one question raised from one of the paramedics was talking about blocks width. So the Serratus anterior plane block just will potentially minimise or eliminate pain related to chest wall injury. And if respiratory distress is because of the pain, by eliminating that pain, then we may prevent any further need for kind of respiratory support, whether it's intubation, ventilation, or parenteral analgesia, really. However, if the respiratory stress is not due to pain, for example, due to underlying pulmonary contusions, hemothorax, pneumothorax, for example, by eliminating that pain, we may have just unmasked that underlying pathology, and therefore you still need to remain vigilant for deterioration and be prepared to kind of intubate, ventilate, and or provide parenteral analgesia, because the SABRE doesn't eliminate that risk whatsoever. But and whilst it may be potentially more comfortable just to immediately intubate a ventilated patient who's got the slightest kind of indication of respiratory distress, it's not potentially in the patient's best interest, and so we have to be a bit judicious with how we manage these patients, and that's why a SABRE is an option for us to consider. Any questions?